Pondeejareon.
Okay. Good morning, Mr. Chairman, Mr. Co-Chairman, and dear colleagues. I'm Chalermpon Pondeejareon, orthopedic resident from Lersin Hospital. My advisor, Ajahn Chali Sumetawanit. Today, I'm going to talk about sagittal pelvic motion in DDH patient 1 year after total hip arthroplasty. For adult hip dysplasia, the post-operative complication rate after total hip arthroplasty are higher than non-DDH patients. And the most common complication caused from the instability and aseptic loosening. In DDH, cause of complication can be divided into two parts. The first one is complex bony anatomy and soft tissue problem. And the second is maybe from increased pelvic sagittal motion. More than non-DDH patient that cannot be restored after total hip arthroplasty. It may be the cause of the dislocation even after the proper implant setting. I would like to describe the pelvic sagittal motion first. The pelvic sagittal motion is the difference between the pelvic tilt of standing and sitting position that affect two different acetabular cup anteversion and inclination. So my research questions are: does the pelvic sagittal motion change after restore or after total hip arthroplasty in DDH patient? If so, can preoperative pelvic sagittal motion be used to estimate postoperative sagittal motion? And the objective of this research, we want to determine the pelvic sagittal motion in DDH patient pre- and postoperatively. For the material and method, this is the analytic cross-sectional study, and we include DDH patient between October 2015 to May 2018 who underwent total hip arthroplasty in Lersin Hospital by single surgeon. The sample size was calculated equal to 19 people. We collect DDH patients who underwent total hip arthroplasty for 1 year and exclude as exclusion criteria. After that, we measure the pelvic tilt angle in sitting and standing position, then analyze the result, discussion, and conclusion. For DDH group, we include known case of DDH and exclude patients who underwent spinal surgery or have contraindication for X-ray. The pelvic tilt angle was measured using the angle between the line connecting midpoint of the sacral end plate to bicoxal femoral axis and the vertical plane. All radiographs were independently measured with a PACS digital X-ray by two orthopedists for a total 3 times. The primary outcome are pelvic tilt angle in standing and sitting position and pelvic tilt difference. Significant change when p-value is less than 0.05. We have 14 patients that underwent total hip arthroplasty. They are all female and average age are 61 years old. Mean preoperative versus postoperative pelvic tilt in sitting position are 30 versus 32 degrees, and preoperative versus postoperative pelvic tilt in standing are 16 versus 17 degrees. The pelvic tilt in standing and sitting position are not show significant change between pre- and postoperatively. And we found that mean pelvic sagittal motion was 14.17 degree pre-operation and 15.79 degree post-operation, and don't show any significant change. So, to summarize, the pelvic sagittal motion is wide variation when patient move from standing to sitting position, unpredictable, may influence implant alignment and cause of asymmetric polyethylene wear, result in hip instability and mechanical failure. And as you know about the safe zone of cup orientation, anteversion should be 15 minus or plus 10 degree, and inclination should be 40 minus or plus 10 degree. Are they sufficient for all acetabular cup, particularly in hypermobile pelvis as DDH? For our DDH patient, when the pelvic sagittal motion changing the position from standing to sitting, pelvis also change from flexion to extension. That effect to the acetabular cup will increase the anteversion and the inclination. And data from 2-year study in Lursin Hospital compare pelvic sagittal motion between normal population and DDH patient. We found that pelvic sagittal motion in DDH patient are significantly larger than normal population. The DDH group, the average pelvic difference is about 17 degrees versus normal population is about 4.9 degrees, especially posterior pelvic tilt in DDH. The result can be implied that DDH patients have more pelvic sagittal motion, more than the normal population. And normal pelvic sagittal motion is about 5 degrees versus DDH has larger about 14 to 16 degrees from our study. The large angle is from the posterior pelvic tilt that affect increased acetabular anteversion and inclination. So it can be because this cause hypermobile pelvis may be one of the cause of the complication. As a result, it's important to understand the relationship of the implant cup orientation in the static pelvis at the surgery to the cup orientation during dynamic postural change, and the acetabular cup setting in total hip arthroplasty of the disease may have to be reconsidered. And the limitation of this study are the study design, which is cross-sectional study, and small sample size and short duration of study may be problem in the power to detect differentiation. And we need the further study to identify proper safe zone for the DDH disease. Thank you.